Thank you very much. This is the fifth of these lectures, and by far the best turnout that I've had in any of them by a considerable margin. So I don't know who I should be congratulating, the organizers, the audience, whoever is responsible. Thanks very much. Great to have such a great turnout. So I'm going to talk about the past, present, and future of evidence-based medicine. And I'm going to start by describing what I think are the three key principles of evidence-based medicine. I'm going to use a historical approach. I'm going to introduce you to the people who, or some of the people who were key in getting it started and its development, and are going to be key to what is happening in the future in evidence-based medicine. And I'm going to end off then with a reflection on EBM in the time of COVID. So the first person I would like to introduce you to, but before I do that, I remember that I was going to say that this is the first article in the medical literature in which the term EBM appeared. And to give you an idea of just how long ago that was, this is what I looked like when that article was published. And then the first person to introduce you to, Dave Sackett. He was my mentor. He relayed the groundwork of evidence-based medicine and was the mentor for other people who came after in leadership roles in EBM. And he made a number of contributions, very important contributions, of which one was an initial hierarchy of evidence. And indeed, the first principle of evidence-based medicine is that some evidence is more trustworthy than others, and we can develop standards to decide what is more or less trustworthy. This is a very simple hierarchy, which served us well for some time. It acknowledges that clinical experience is a legitimate source of evidence. Basic research can be valuable, but generalizability is a problem. Observational studies can tell us what happens out in the real world, which unfortunately may not be what happens when you actually apply intervention in the real world, because in observational studies, those exposed and non-exposed may have very different prognoses. And so we have randomized trials at the top of that hierarchy. As I say, this is a very simple hierarchy that served us well for some period of time. Later in this talk, I'm going to introduce you to a much more sophisticated hierarchy that we use currently. Next individual is Ian Chalmers. Ian Chalmers was the guy who had the idea, excuse me, of the Cochrane collaboration, and indeed was the engine to do the work and to do all the organization and set up the first structure that has ended up making Cochrane very successful. And Cochrane is all about systematic reviews, primarily of randomized trials. We call this a forest plot. How many people in this audience are familiar with plots like this? Okay, almost everybody in the audience. 15 years ago, when I would tour around in front of medical audiences and I would put this up, I would have to go through and explain it. 15 years later, I go to audiences, this one, I believe just about everybody put up their hand. That's true when I go to medical audiences of all sorts, all around the world. And it's very gratifying to see that the impact that evidence-based medicine has made, that everybody around the world in the medical area can now recognize what these things are all about. So this one is a forest plot about thrombolytic therapy after myocardial infarction. It is starts in the late 1950s. And in the late 1950s, the first randomized trial of thrombolytic therapy enrolled only 23 patients, and as a result had a very wide confidence interval. The second one enrolled not 65 patients, but 42. This is a cumulative meta-analysis. It's not the ones that you're used to seeing where each line is a trial. Here, it's all the trials together. So by 7 trials and less than 2,000 patients, you still see that the confidence interval overlaps no effect and has not yet established thrombolytic therapy as useful. 10 trials and 2,500 patients, now the confidence interval does not overlap no effect, and it begins to suggest the usefulness of thrombolytic therapy. We may then have a discussion about when the answer was in, when people should perhaps have stopped doing randomized trials. And most of us, I think, would say around 30 trials of over 6,000 patients. Now the confidence interval is a long way from no effect, and we're getting very low p-values. It seems to be established that there's a 25% reduction in the odds of dying with thrombolytic therapy. Did this stop the trialists from doing their trials? No, it did not stop the trialists from doing their trials. And indeed, there was another 40,000 patients enrolled after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why did they need to enroll? Why did they need to keep doing these trials? Well, when I talked to some of the people who were doing them, they told me the cardiologists just weren't getting it, and we just had to keep doing trials until they did. And that's illustrated on the right side of this slide, which shows the recommendations made in current textbooks and journal articles by cardiologist experts who said thrombolytic therapy should either be routinely administered, specific indications, experimental, or not even mentioning it. And two things. One, the wide disagreement between experts. Here in the latter part of the 80s, you have people saying from routine to not mentioning it. And it is a decade after the answer is in that you finally have the cardiologist approaching a consensus on the matter. And I'm going to tell a second story. The story is also a story about myocardial infarction. And particularly my personal perspective on this story is that 45 years ago, when I was doing my internal medicine training and rotated through the coronary care unit, every patient who came through the door, I started what we call a lidocaine drip, an intravenous infusion of lidocaine. Well, we knew that people after myocardial infarction are at risk of lethal arrhythmias. It made total sense to give them a nice antiarrhythmic therapy. However, in this case, was there ever any randomized trial evidence to support what we were doing? No, there was not. If you look, in this case, the point estimates are always on the harm side. Increased mortality with lidocaine. Did this stop the cardiologist from recommending it? No, it didn't. And the 20 years that these data were accumulating, you see most of the cardiologists were experts were recommending it. That's why I was giving it. Although, again, you have lots of expert disagreement. Now, these are old stories. They end about 1990. And although experts still disagree and they still get things wrong, probably not as egregious mistakes as you see in these two examples. Something happened in 1990 to make it less likely that you would have that degree of expert disagreement, and experts 10 years behind the time are making recommendations actually completely out of keeping with the results of randomized trials. Anybody like to make a suggestion? What happened in 1990 that changed the picture? Anybody like to make a suggestion? Well, for those few of you looking out who were around in 1990 to see what was going on, you would remember that there weren't any systematic reviews and meta-analyses in the medical literature. Systematic reviews and meta-analysis only started appearing in the medical literature after 1990. And I would contend that if the experts had seen the forest plot of thrombolytic therapy, there would have been a consensus in its favor much earlier. And if they had seen these forest plots, they would not have been recommending lidocaine. So which then highlights the second principle of evidence-based medicine. We need systematic summaries of the best evidence to deliver the optimal care to our patients. This is Brian Haynes. He was the chair of my department, which when he was the chair for a decade, It was clinical epidemiology and biostatistics, and he made a number of very important contributions to EBM. One was captured in this paper, which was published in the BMJ in 2002, where he made the point that evidence does not make decisions, people do. What are the implications of that? Well, the implications are that we need to pay attention to patients' values and preferences. Hilary Llewellyn-Thomas and Deb Ryan was two of the people who did work in values and preferences. Sorry, it's Annette O'Connor did work on values and preferences. And to illustrate the importance of values and preferences, I'm about to enroll you in a study. And this study is going to be a replication of a study that P.J. Devereux, who is now leading the world in perioperative medicine, did a number of years ago. And he took the situation of patients with atrial fibrillation, and he told his study participants that without treatment, patients are going to have 12 strokes, 6 major and 6 minor. He pointed out that anticoagulation is effective in reducing strokes in people with atrial fibrillation and would decrease strokes from 12 to 4, 8 fewer strokes, preventing 4 major and 4 minor strokes. And the question that he asked his study participants, who were both patients and clinicians, and I will be asking you in a minute, how many serious gastrointestinal bleeds would you accept in 100 patients and still be willing to administer as a clinician or use as a patient to prevent strokes? And you had patients who were enrolled. He had to explain to them what it is to have a stroke and what it is to have a gastrointestinal bleed. So a minor stroke, suddenly can't move or feel one arm and leg, difficulty expressing yourself, admitted to hospital, you gradually get better, you're left with a minor disability that allows you to basically resume your prior life. Much worse if you have a major stroke, unable to move an arm and leg, can't swallow or control your bladder, unable to talk, admitted to hospital, can't dress, walk, nurse feeds you. After a little while, after a month or so, you have some improvement, but you still are left with major disability for the rest of your life. So that's a major stroke. So we now know what a minor and major stroke are. And Dr. Devereux also explained what it is to have a serious gastrointestinal bleed. You feel unwell, you don't feel well at all, suddenly you vomit blood, pretty frightening. You come to the hospital, you have an endoscopy, receive sedation, receive blood transfusions, and a week later you are on your road to recovery and can leave the hospital. So that's what it is like to have a serious gastrointestinal bleed. So back to the question. Without treatment, 12 strokes, 6 major, 6 minor. With anticoagulation, 4 strokes, so 8 fewer, preventing 4 major and 4 minor strokes. And the question, how many in 100 patients of those serious gastrointestinal bleeds would you be willing to accept and still use the anticoagulant? All right, who would accept 5 or fewer bleeds? More than 5 bleeds, no anticoagulants. Hands up. A couple of people, 3, 4 people. How many, once you've put your hand up, don't do it again. Who would accept up to 10 bleeds and still use anticoagulants? But more than 10, no. Who would accept up to 10? Okay, we have another 3 people. Who would accept up to 15, but no more than 15? Another bunch, maybe a little more than the others. Who would accept up to 20, but not more? Quite a few people up to 20. Who'd accept more than 20? Anybody more than 20? Lots of people in this audience more than 20. Very interesting. How many people are physicians in this audience? Most physicians, okay. Mwah, very good. I'm quite impressed. Okay, so so now what happened with the patients and the physicians in Dr. Devereux's study? Yeah, sure. Dr. Devereux had about 60 patients and 60 physicians. He asked it both to the 60 patients and the 60 physicians, and I'm now about to tell you what happened with the patients and what happened with the physicians. So with the physicians, it's the green-blue, and basically you get a flat distribution. And I've asked this question to many largely physician audiences over the years, and I've more or less replicated. This is a audience that was, I would say, a little bit different. You have more people up at this end than in Dr. Devereux's initial study. But like Dr. Devereux's study, you had a few people say 5 or less, and a bunch of people more than 20. In other words, big differences in how many bleeds you are ready to tolerate to prevent 8 strokes. And what do we call this? In evidence-based medicine, we call this different values and preferences. And so what you see here, well, in a minute, so here's the patients. They are very different. 2/3 of the patients are ready to accept 22 bleeds. Why 22? Seems like an odd number. And Dr. Devereux, when he did his study, he was thinking like a physician. He didn't think they'd do more than 22. If they'd been given the chance, they would have. So, message is the patients are much more stroke averse and much less bleeding averse than the physicians. The physicians are much more bleeding averse and much less stroke averse than are the patients. And the message is, if we substitute our physician values and preferences for our patient values and preferences, we've got a problem. We're not going to give patients what they need. But there's another key message in this, and the message is that although most of the patients are up here, there are a few of them down here who have values and preferences closer to those of the physicians and are much more bleeding averse and much less stroke averse. And so if we are to get it right for our individual patients, we have to find out their individual values and preferences. This then are the 3 key principles of evidence-based medicine. 1, some evidence is more trustworthy than others, and evidence-based medicine suggests a hierarchy to allow us to make that distinction. The best clinical care requires systematic summaries of the best evidence. You see how badly these very smart cardiologists went wrong when they didn't have such systematic summaries. And thirdly, the perhaps ironic 3rd principle of evidence-based medicine, evidence by itself never tells you what to do. It's always evidence in the context of patient values and preferences. Next person I'm going to introduce you to is Andy Oxman. He was with us at McMaster for a decade, then went to Norway, where he now is recently retired. And he came up with the idea of a way of looking at evidence and evaluating it and moving from evidence to recommendations that we have called GRADE. So a system to judge the confidence or certainty or trustworthiness of evidence from systematic reviews. And it also gives you an idea of how to move from the evidence to the recommendations. And as it turns out, since the first publication in the BMJ in 2004, this has proved a big success. Over 120 organizations worldwide are using GRADE. They include prominent ones like the World Health Organization, major American organizations like the American Thoracic Society, American College of Physicians, the National Health Service in Britain, and indeed, perhaps the most important one from my point of view, which I should say Cochrane Collaboration, and UpToDate. So UpToDate is the #1 resource worldwide. When I go around the world, ask clinician audiences how many using UpToDate. very widely used all around the world, and up to date has over 10,000 rated recommendations. So, well, how does, I remember Dave Sackett's very simple hierarchy of evidence. Here is the more sophisticated hierarchy we have now. Evidence, according to this grade system, can be high, moderate, low, or very low. Randomized trials start as high certainty evidence, but they may not end up there. Trials may be unconcealed, unblinded, and lose large numbers of patients to follow up, and so be less trustworthy because of risk of bias. They may have small numbers with wide confidence intervals for imprecision. I work as a hospital-based general internist, try to base my practice where possible in randomized trials. Many of my patients are now over 80 and now quite a few over 90. Patients that old were seldom enrolled in those randomized trials. And so when I apply the results, I have to be a little bit cautious. So the direct evidence from the randomized trials in younger people provides indirect evidence for my older patients. The results may differ from trial to trial, inconsistency, and we may be worried about publication bias. So that randomized trials start as high, but because of these problems, several of them may exist in a group in a systematic review of randomized trials, so it may be moderate, low, or even possibly very low certainty evidence. Now, observational non-randomized studies start as low because of the biases associated with different prognosis in those exposed and non-exposed. And it can go to very low because they may have additional problems like this. But clinicians in the audience, what do you do in your clinical practice, interventions that you apply that have never been tested in randomized trials, but you know they work? You know that patients do better because of these interventions. Who would like to suggest an intervention that you use in your practice, no randomized trials, but you know it works? Parachute. You do not. You have a very interesting cardiology practice. Pardon me? Point of care ultrasound. What outcomes does it, are you absolutely sure that people are better, didn't happen before, and now, or bad things that happened before and don't happen now because of point of care ultrasound? Potentially, right. Okay, that needs randomized trials. Point of care ultrasound, I'm not sure anybody's better off. Maybe, potentially, needs to be tested. What are you sure of? Come on. You have to take the best evidence you've got. I would suggest to you that that's absolutely right, and there's other areas where randomized trials are very difficult. Please acknowledge that you're not sure, okay? But what are we sure? There are some things we're sure about despite no randomized trials. Yes? Sorry? Right, okay. There's one that we can be confident about. Resuscitation after cardiac arrest. It used to be everybody's dead. No. Now, some people survive. Hunger, you don't need a randomized trial. Okay, good. Another one. It's the one over here. Steroids for polymyalgia. I can't say how big. I'm skeptical. Yes. Yes, dialysis. Before dialysis, you had terminal renal failure. That's it. Bye bye. Okay. No longer. Yes. Epinephrine for anaphylaxis. Okay, I'll agree with that one. Maybe. Okay, so there are a few. So the ones I'm confident about is resuscitation after cardiac arrest, epinephrine for anaphylaxis, dialysis for renal failure, intubating somebody whose PCO2 is 100 and rising, and hip replacement for people with downhill course on degenerative osteoarthritis. I have two of them, so I know. Okay, all right. Okay, so we've said observation studies start as low certainty evidence, but they may end up as moderate or even high certainty. What? Yes. So, okay, so hang on. I need to keep going, or I'm not gonna finish. But thank you. Physiologic plausibility. Okay, I'm just telling you, EBM, very low value on physiologic plausibility. We need to see evidence on patient-important outcomes to really be convinced. So, what the examples that we've had that we've just gone through? What do they all have in common? Sorry. Not the hip replacements, maybe over the long term, okay? No, so that they don't all have that in common. Some of them do. Oh no, there's lots of things we can't do randomized trials, and just because we can't randomize trials, we don't say success. No, no, no. That's not the way it works. Sorry? Big effect. They all have very large effects. Everybody or almost everybody used to do badly, typically downhill courses. It's reversed, the trajectory is reversed, and now you have some people, at least often a lot of people who do well, where everybody used to do badly. Very large effects. So that's what they have in common, and so observational studies can end up as high certainty evidence. And this is how GRADE likes to summarize the evidence in what are called evidence profiles. Here is one about baricitinib in patients with severe or critical COVID. Outcomes on this column: mortality, mechanical ventilation, hospital length of stay. Relative effects in the second column. What's important to patients is not relative but absolute effects. That's in the next column. If this odds ratio of a 38% odds reduction is true, the baricitinib would lower mortality, which was at 13% to 8.5%, but of course there's a confidence interval around that. Next column is the certainty of the evidence, and finally a plain language summary that baricitinib probably reduces mortality. So that's how GRADE evaluates the certainty of the evidence or quality of evidence, and how it presents it in summary of findings tables, but it also provides guidance for going from evidence to recommendation. Only two categories of recommendations: strong or weak, synonym conditional. Strong recommendation is when the benefits clearly outweigh the downsides, or the reverse. What can take you from a strong recommendation to a weak recommendation? One is you only have low certainty in the benefits and or the harms. If to make a strong recommendation, you have to be very confident that the benefits outweigh the downsides. If you're not certain of the benefits and downsides, you can't make a strong recommendation. Or you may be confident about the benefits and the downsides, but they may be closely balanced. And what we've already learned about values and preferences in this audience and in our patients, values and preferences differ. And when the benefits and downsides are closely balanced and values and preferences differ, people are going to make different choices, and you need a weak or conditional recommendation. We like this dichotomy, just saying strong and weak or conditional, because it has implications for our practice. And nice way that we like to think about strong and conditional recommendations is that you make a strong recommendation when, if you presented the choice to fully informed patients, all or almost all would make the same choice. On the other hand, a conditional or weak recommendation is when the majority would choose, hopefully, the recommended treatment, but a minority would choose the other, because they have different values and preferences. Now, when I go, I've been very privileged in many ways in my life, one of which is I get to go around the world and talk to clinician audiences. And when I do, there's one question I ask that they always give the same answer. 100% or almost 100% of the people answered the question the same way. And that question is, do you have enough time to spend with each of your patients? And the answer is universally no. So that means that we have to ration our care. We have to ration the time we spend, and we have to use our time wisely with our patients. And grade helps with that. If a panel has made a strong recommendation and got it right, if we did go through a full shared decision-making exercise, everybody or almost everybody would make the same choice. And so we can just tell the patient, here's what I think you should do, and here is why. A situation where a guideline panel gets it right and makes a weak or conditional recommendation is one when a fully shared decision-making process, people are going to make different choices, and if you want to get it right, you then have to spend your time with the patient on that situation. So you have situations that are value and preference insensitive, strong recommendations, and then they are value and preference sensitive, and that's a conditional recommendation. And finally, shared decision making is tough. More and more we have decision aids, which are probably not a great use of time when you have a strong recommendation, but would with a conditional. So, guidelines, you have to use average values and preferences. But we have just heard people's values and preferences differ, and when you have a value and preference sensitive recommendation, if you want to get it right for the patient, you need to engage the patient in that decision. And that can be challenging. Next guy I would like to introduce you is a professor of medicine at the Mayo Clinic, worked with us at McMaster for a couple of years, and is a world leader in this process of shared decision making. Victor is an endocrinologist who specializes in diabetes, so he talks to diabetic patients very often. And nowadays, there's a whole bunch of different treatments we can give for diabetes. And Victor says to his patients, there's various things where these treatments differ one from the other, and they differ in their effect on your weight, on the effect of they give hypoglycemia, on the extent to which they lower your blood sugar, on their daily routine, the sugar testing, and the cost. Which of these issues would you like to know about first? Pick one of the cards. What card do you think is the most popular first choice among Victor's diabetic patients? Cost is one, yes. Any others suggest? Cost if you're an American. Cost if you're a Canadian until we have universal pharmacare. Quick change is the most popular, okay? And then they may ask about daily routine, and they may ask about cost, and they may ask about all six. But they never do. Most they will ever ask for is 4, often 3, sometimes just 2. So here we have now got very efficient, evidence-based shared decision-making which focuses on what the individual patient wants to know and thinks is important. Sure. Probably, but how it has changed, I haven't talked to Victor about. But from the past, here is an example of Victor going through the process.
so as to use the reality of the party is not what we expect. We can do this again and we can more than
Evidence-based shared decision-making in less than 2 minutes. Doesn't always go that smoothly, but you can get an idea of how this facilitates shared decision-making. Deborah Cook and Maureen Mead are intensivists who've led the world in evidence-based medicine in the intensive care. And Deborah Cook has particularly brought a remarkable innovation, in my view, which she calls the Three Wishes Project. And what she does is take people who's in the last stages of life and ask them and their family about three wishes. So it's to improve the dying process, for patients to honor their dignity, for families to humanize the dying process, for ICU clinicians to inspire a deeper sense of vocation. Wishes can be very simple, flowers at the bedside, or somewhat more challenging, having a wedding ceremony performed at the bedside. Deborah has conducted many and led and supervised many multi-center mixed method studies. And what matters most at the end of life is simple. This has been widely adopted internationally, the Three Wishes approach to humanize the dying process. The main people, Per van Beek. Per van Beek is a Norwegian who studied with us about guidelines and addressed the question of providing evidence-based care most efficiently. So when the guidelines we used, it was for the American College of Chest Physicians, we used GRADE, we thought we had a great guideline. Per wasn't so sure. He said, are they available, useful, and understandable? Maybe. Are they suited for integration into electronic medical records, EDM textbooks, and adaptation? No. Sufficiently up to date? No, we did it the way guideline organizations typically do it. They put out the recommendations. They're tired enough that they rest for 3 years before they do it again. And in the interval, things change and the recommendations are out of date. Do they facilitate shared decision-making? Definitely no. And so Per asked himself, how can we make GRADE irresistible for clinicians, patients, and developers? And he decided that what we need to do this is magic. MAGIC stands for making GRADE the irresistible choice. So, and part of making guidelines work is to move toward what we call living systematic reviews and guidelines, where the new evidence comes up and you update your guideline. Per made a negotiation with the BMJ to produce BMJ rapid recommendations, where we look for new practice-changing evidence, quickly do an updated systematic review. We now know how to do them quickly put together a trustworthy guideline, and come up with a current recommendation, which is published as a BMJ rapid recommendation. And another aspect of MAGIC is the MAGIC app, an electronic platform which allows you to have, and I'll show you in a moment, allows you a tiered, layered approach to guidelines, and you can put them on the app, integrate them in the electronic medical record, facilitate adaptation and decision aids, and I'll tell you a little bit about that as well. Last person, no, it's not the last. It's near the last person I'm going to introduce you to, Thomas Agaritzis, who did a PhD with us in Hamilton, subsequently is working closely with Per, leading the MAGIC organization. And one of his innovations was in the decision aids we need, ideally for shared decision making. And he took advantage of the structured systematic reviews that you get when you have great principles, the evolution of decision aids with Victor's approach to targeting it for the individual patient, and the MAGIC app. And that allows the semi-automated production of decision aids. During COVID, the evidence was being produced very quickly. Two groups in the world, one of ours at McMaster with Reed Semenchuk and Romina Brignardello, who are young faculty members, put together a team of over 60 methods people a lot of graduate students in that crew, and we're processing up to 20 randomized trials a week at the peak of the epidemic, and producing a network meta-analysis, a recent innovation, relatively recent, in evidence-based medicine. It used to be one treatment, one comparator. Now it is multiple. You can compare multiple treatments simultaneously. They produce these, and they produce the evidence for anybody who wants to make a guideline. But in particular, the World Health Organization, which MAGIC was working with and made an arrangement with BMJ, so that the World Health Organization COVID guidelines, the day they come out, they're also published in the BMJ. So two different audiences, the WHO audience and the clinical audience in the BMJ. And what is, it's published in the BMJ, but where is my cursor? Nope, I didn't want to do that. I want to get to my cursor. There we go. So this goes, what I'm going to show you is what appears in the MAGIC app about the guidelines, the COVID guidelines. And I need to find my cursor again. Over here. Oh, I'm sorry. Technical glitch. Which I better. If anybody sees the cursor, you tell me. Yeah, I see it now. Okay, thank you. Okay, nirmatrelvir ritonavir is the best medication for non-severe COVID. And this recommendation, oh gosh, Peter will tell you that this doesn't always happen to me. Okay, so we go to, and so we have a strong recommendation for non-severe COVID in patients at high risk of hospitalization. For patients at moderate risk of hospitalization, WHO gave a conditional recommendation. So that's the first thing you want to know. And maybe some clinicians will stop there and say, okay, I should give nirmatrelvir ritonavir to moderate risk patients because of decrease in hospitalization. But they may want to see more details about the research evidence. And so if they do the appropriate clicks, they can go to they can see one of the summary of findings tables. Remember the summary of findings tables that I showed you? You can see that. And they can look at the evidence to decision framework. Grade says look at benefits and harms, certainty of evidence, values and preferences, resources, and other considerations. They can see a justification for the recommendation. They can look at practical information about route, dosage, and duration, and in this case, the contraindications. There's lots of interactions with the nirmatrelvir ritonavir. And this may be the sort of physicians just look at the recommendation and then go straight to the practical information. Or some may go to a decision aid. And the decision aid, you notice 3, mortality and admission to hospital. That's for the high risk, the moderate risk, and the low risk group. And it's shared decision making. The physician may say to the patient, the real action, which is where it is in the hospitalizations. And I've actually, I think, clicked on the low risk, but we'll show you it doesn't really matter. In this case, for the low risk, you're going to have a reduction in hospital admissions from 21 to 5, and the patient may be a little challenged with the arithmetic, and they may go then to this, which shows the 1,000 representations of patients, the 16 that are going to be hospitalized if they don't use nirmatrelvir, the 5 that are going to be hospitalized, and the 16 less represented. So you can see a layered approach to guidelines where the clinicians can see as little or as much as they would like. So I think we are back here. And so finally, EBM in the time of COVID. So one of the things that happened is that we had an innovative trial design, platform trials, where you set up your platform and you test one treatment, and then you use the same platform to test the next treatment and the next treatment. So you're not starting each time, and that made the production much more efficient. Recovery, Solidarity, and REMAP-CAP were three of these platforms that provide major evidence. And the result was within 2 years from when we started these trials, we had 3 treatments that we knew reduced major events in patients with non-severe COVID, and 3 classes of treatments that, through randomized trials, we show reduced mortality in serious and critical COVID. Unprecedented cooperation among trialists, sharing the information, which should always be done. Collaborations like with the WHO, with MAGIC, to do very rapid evidence summaries and evidence summaries, living living systematic reviews and guidelines. So, in summary, the 3 principles of evidence-based medicine are widely acknowledged. The first, the hierarchy of evidence. GRADE represents, some evidence is more trustworthy than others, and GRADE now presents a quite sophisticated and we think very valuable way of deciding what is more or less trustworthy. Need for living systematic summaries. You saw how badly the very smart cardiologists went wrong before they had those available. And the ironic third principle, evidence itself never tells you what to do. It's always values and preferences along with the evidence. COVID, to me, has been a good example, at least within the area of pharmaceuticals, the full potential of evidence-based medicine, the rapid accumulation of trustworthy evidence, and incorporation into state-of-the-art evidence summaries, and then the rapid production of guidelines. So that's what I wanted to tell you about evidence-based medicine. Happy to have any questions, comments, reflections that you want to share. Yes.
And you have to get what the thing is that we've never had data, evidence-based medicine data, never been more available to us than it is now and to the public. Why then the disconnect from what we see in the world, seemingly in the States, where people are not believing this information?
Okay.
Robert J. Kennedy, things like this.
So I often get questions of this sort, and with the sort of training I have had and the person I am, I think, what is the evidence that is available to answer this question of why we have everything, we have all the evidence available, but people are not doing the right thing? And I think to myself, I am very unfamiliar with the evidence, if indeed there is any, and so I am not qualified to answer your question. In fact, I'm not even sure whether it's in the area of sociology, political science, social psychology, where the evidence may be that it lies. That's how out of it I am with this. So I'm afraid we're going to have to go to somebody who knows a little bit about that evidence to get a reliable answer to your question. Yes. Okay. So it is becoming clear that the output from the clinical end should be the same, except as you are suggesting, we're getting pretty good at producing it quickly now, but it will be even it will be produced more quickly. AI is clearly going to make the process of summarizing the evidence and applying grade to get at the certainty of the evidence. It is going to make that process much quicker and probably pretty soon in the future. It's not quite there yet, but it's getting there. So fortunately, we'll be able to do, I think we've got to be COVID showed we can do this process pretty quickly already. We're going to be able to do it even more quickly with the application of AI tools, for sure. You'll have to shout. Okay, so men versus women. Many in Canada, CHIR for randomized trials says we must look at differences between men and women. NIH, I think, has the same thing. This is a big mistake. The reason that it is the big mistake is that overwhelmingly, or certainly within the area of pharmaceuticals, there are very seldom important sex differences in the impact of the treatments on the outcomes of interest. Now, what is going to happen when every trial has to look at differences between men and women? The answer is you're going to get a huge number of false positives where there is truly no difference between men and women, but because you're doing the test over and over and over and over and over, for 5% of the time, you're going to hit your under 5% of an interaction between men and women. So we in the trials that I'm participating in, we're forced to do it when we find the result, unless we have a biological a priori hypothesis that there might why there might be a difference, which we almost never do. We'll do the test. If it's positive, we're not going to tell anybody. Okay, as far as we're concerned, somebody asks, we'll tell them, but we're going to ignore it because all it's going to do is lead to false positives that is going to be big trouble for men and for women.